Now, this is an introductory session or introductory class on thorax, where we are going to briefly discuss about how we are going to approach to study to the thorax of human body, and the content, the way of studying the thorax or thorax cavity is little bit different than what we have done in upper extremity or any part. So every section of anatomy study will be different than that of wrist part, and there will be study plans will be accordingly you have to adjust it. Now in thorax for the day we are going to talk about like general introductions. What do you mean by thorax, and what are the delineation or what are the boundaries of it, and how we are going to learn that particular thorax in sections. So today and tomorrow as well we are going to cover some sections of the thorax, and it will be followed next week or next week 2 weeks onwards, which includes the theoretical discussion, practical discussion, demonstration classes and histology as well in thorax. Now today's learning objective, which we are going to cover in next 45 to 1 hour, is going to be the general introduction of the thorax. What do you mean by it? How we are going to study the thorax? We are going to talk about the thorax in terms of the thoracic cavity and thoracic wall, that means the boundary of it. We have to talk about this particular thoracic cavity later on. Before that we are going to study about the thoracic wall or boundary, which is the point of concern today. So what do you mean by the thoracic wall? What composed of this particular thoracic wall? What are the contents that is important to us? What is clinically relevant to us? We are going to do. And how this particular thoracic cavity and thorax content is going to be delivered as a clinical case or as a anatomical study, we are going to talk. Now, most of this particular thorax or thoracic anatomy, the clinical part of it is very well covered in Moore's clinical oriented anatomy, which I very keenly follow. The books which you are following, they are also very good, but the clinical part is very nicely demonstrated there. So if you just like combine this particular study, whatever you are making or whatever you are studying with this your textbooks along with this particular clinical oriented Moore's book, that will complete your study part on thoracic clinical anatomy and as well as the gross anatomy as well. So having said that, this is the content that is going to study bony thoracic wall, boundary, surface anatomy, ribs components we are going to talk in the demonstration class, and we are going to talk about this particular composition, so which is composing with this particular thoracic walls like muscle, vessels, nerves which is present, and we will briefly discuss about this particular respiratory movement or chest wall movement and the muscles involving this particular respiratory movement. So this is our aims and objectives for this class today to discuss about. So to start with this, we talk about the thorax, which is a section of the body, we call them as trunk. Trunk means that part of the body which is the centrally placed and it is extending between the neck region and the lower abdomen. So this entire region up to this particular like the groin region, we call them as trunk. Now this thorax is present from this particular neck region to this particular abdomen or abdominal partition, which is limited by a muscular partition, we call them as the diaphragm. So to neck to this diaphragm we have this particular extension of the trunk, we call them as thorax. Now the thorax, whenever we are going to study, we are going to study in two sections. One is we are going to study today is that we call them as thoracic wall, which is the boundary, and next onwards the other component will be getting in the cavity which is covering this particular wall, which is known as thoracic cavity. So that particular thoracic cavity will be covering nextwards. So this study we are going to talk here today is this particular boundary wall or thoracic cavity. This is made of bones, cartilages principally, front and back side, and it's kind of like a little bit rigid cavity more or less, which is present in this region. So this study will be limited to this particular thoracic wall or this particular delineating part, and inside to it, if you just like cut here, inside to it we find this cavity, and this particular cavity also can be divided into three sections, the central part and two lateral parts. We call them as right pleural cavity, left pleural cavity, and the central part we call them as mediastinum. So we will be learning that in subsequent classes. For now we are focusing on the boundaries of thoracic wall. So this particular thoracic wall we are going to talk about, and we are following here. So, whenever you're going to study this particular thorax or thoracic wall, it has some kind of borders or landmarks that you need to follow. So, it has some kind of features which is present in it. So, we have this particular clavicle present over here, and we have a depression over here. We call them as jugular notch, which you can feel out here, which is on the top of this particular bone, sternum bone. And the lower part, we have this particular ribs, we call them as costae or costal margin, which is roughly corresponding with the attachment site for the diaphragm, right? And in the midline, we have the bone, we call them as sternum, which is present in here. So, these particular features which are kind of like a familiar with us, jugular notch, clavicle, and this costal margin, which is fitting with these diaphragms, which is present to it. Now, in this particular midline, where the sternum is there, which has got few parts of it, and these parts of the sternum, we call them as upper part, we call them as manubrium. Then we have the body and the xiphoid process at the bottom side. The union point of this particular manubrium and the body, which has an angle, we call this angle part as the sternal angle, also known as angle of Louis. So, that landmarks is important to us. Apart from these landmarks, we have some other surface anatomy landmarks that you have to know. Whenever you are studying this particular part will be more relevant, more important whenever you are going to study this in physiology. So, likewise, we have the boundaries. That means, we are saying the upper boundary, which is limited by top of this collarbone, we call them as clavicle. So, this is the upper boundary which is present roughly on this region, which makes this particular upper region of this thorax. The lower limit, which is roughly corresponds with this costal margins, bottom side of it, which is fitted with this muscular partition, we call them as diaphragm. And this particular diaphragm moves up and down whenever you are breathing in or breathing out. So, it has a kind of like a adjustable boundaries on the bottom side, but upper side is more or less fixed structures. Now, apart from these particular boundaries, we have kind of surface lines are there. This surface line matters to us whenever you are doing some clinical examination, which is very important for us. In our throughout life, we will be just like studying a patient. So, whenever you are studying a patient, we have to follow these lines. So, we call them the midsternal line, that is in the midline, which is present. Then we have this particular line, we call them as midclavicular line. So, which is the midpoint of the clavicle. We take the length of this clavicle right to left, and we find the middle portions of it, we call them as midclavicular line. Now, if you go from front side, if you move to lateral side, we find some lines which is related to the axilla. We call them as axillary lines, we call them as anterior axillary line, posterior axillary line, and in between we have the middle axillary line, likewise. So, anterior axillary fold, we find it, we call them as anterior axillary line. Posterior axillary fold, we find it, we call them as posterior axillary line, and the midline. Now, why this line matters? Whenever you are doing clinical examination, whenever you are hearing this breath sound, heart sound, these particular lines will be coming back. We will be following these lines, and following this line, we trace this particular organ, and part of that particular sections of the organ can be traced. So, clinical knowledge of these surface markings of this line matters. Similar to that, on the posterior side, we have few lines, which is this line, we call them as mid-vertebral line, which is the spinous vertebra, midline, right, on the back side. And this line, which is corresponds roughly with this inferior angle of the scapula. If you draw a vertical line, we call them as mid-scapular line. So, these particular lines or surface lines is giving us a clue to identify a patient whenever you are going to do any clinical procedure, either examining the patients or doing some interventions like surgery or some kind of interventions. This matters to us. So, these are the roughly the lines that we are coming back again. No just like a big words about it, just like know this what do you mean about it, right, and how this particular things is relevant to it will be coming once again. So, this is what you will be studying in like one line or two line thing, what do you mean by these particular lines and the significance of it. Now, as we are saying, this particular thoracic wall or this particular cavity which is covered by this particular wall is made of bones. So, there are a few pieces of bones which is making this. So, bony cavity is front eyes, we have the sternum which is fitting in here, and from the midline we have this particular ribs, and right side left side together counting we have together 12 pairs of the rib. So, we can classify this particular ribs based on how they are attached and how do they perform or how do have features. So, we can classify these ribs as a true ribs, false ribs, floating ribs, which are familiar with us. We learn this particular ribs classification in 10+2. If not, we will be learning in demonstration class as well. The other way, ribs can be classified based on if they have some typical feature, that means they look alike, we call them as typical look. They are kind of similar, and some of them are dissimilar. They are not just like likewise the other one. We call them as atypical rib. So this is how we are going to study the ribs. But anyways, so this bony cage is formed by this particular ribs and the sternum, and the back side we have the bone, we call them as vertebra. The vertebra which are present in this region, thoracic region, we call them as thoracic vertebra. So we have 12 pairs of the rib in the front or the lateral side and 12 vertebra on the back side, and we number it like T. T for the thoracic section. Also it can be called as dorsal or D. D for dense kind of thing. So D or T are for the same reason. We call them as T1 to T12, which is for the thoracic vertebra, or ribs, which is we call them as rib 1, R1, R12, like that. So this is we are going to study. So this is what we have talked about, and this angle we refer here as angle of Louis or sternal angle. It has some features which you have learned, like this particular point where you are fitting with this particular rib counting begins, where the second rib fits in, and this particular region where we have this particular thing, there are a number of features happens, like arch of aorta begins and ends at this particular point. There is a change of course of this particular thoracic duct. We have this particular mediastinum, or the central cavity can be divided into two parts, above this particular T and below this particular T2, which is known as this particular superior mediastinum and inferior mediastinum, etc., etc. So these are the lot of things which can be demonstrated based or can be discussed about this particular angle of Louis or sternal angle. We are not going into it because that's a demonstration class topic. Now the clinical point regard to this particular bony cage wall. Now if you have to do any surgeries inside to it, like for example lung surgery or heart surgery, you cannot just like go inside all the time by doing some kind of small holes and putting this particular instrument inside. So sometimes we have to open this chest wall. We call them as thoracotomy. So this particular thoracotomy, which is making an incision through these particular bones, cutting through the ribs or this particular sternum, and getting inside and doing surgery, like heart surgery or lung surgery or any delicate internal surgeries which is related to this particular thorax wall. So for these we have to cut this particular thorax and do the surgeries. Now while doing this particular thoracotomy, if you are cutting this particular sternum in the midline, we call them as median sternotomy. This is to gain access to do a surgery or do a procedure inside to it, right? So this is the clinical words, maybe just like a popping up in some of the clinical situations. So we have to now know about thoracotomy and sternotomy, and there will be other clinical words that will be coming up again. So we will be just like able to understand the difference of the meaning of these particular procedures, whatever given in the clinical context or the other clinical point related to this particular rib cage. Now this particular bone is a flat kind of bone, it's the sternum bone, right? Now this being a sternum is a flat bone, it is an accessible subcutaneous bone. What do you mean by the accessible subcutaneous part of bone? That means it is lying right under the skin and it is accessible. That means easily we can penetrate. Sometimes if you have to do a study of these particular blood cells, we have to study the blood production houses. We call them as bone marrows. So bone marrows are the space where from the blood cells like RBC, WBC, platelets are produced off. Now where these particular bone marrows are there? The bone marrows are present on the ends of the long bones and these bodies of the flat bones, like this particular bone, we call them as hip bone, which is present in here, and this particular bone, which is a flat bone over here, we call them a sternum. So sometimes we have to do a study of the bone marrow, which we prefer to choose this flat bone. So this particular bone marrow biopsies, we often do a needle bone marrow aspiration, pierce this particular sternum, the outer quadrant, and get inside the middle portions of this particular body of the or manubrium part of this particular sternum and do this particular procedure. We call them as bone marrow biopsies. Now, if you are putting a needle and breaking this particular outer table of the bone and getting on the depth of this particular bone to trace for this particular bone marrow, we have to be delicate. Why? If you put too hard pressure on this particular bone, it might break this particular part and break this particular bone through and can enter to this particular space within this particular region. We call them as mediastinum. And the central part of the mediastinum, right behind it, you see that the heart with this particular giant vessels coming, we call them as aorta. So if you are pressing too hard, then we might break these things. When, especially if you are doing it for the kids, young individual, they are very thin plate bones. Older individual, the bones are kind of like demineralized, or they are weak bones. So if you are just like a very strong guy coming after doing tons of gym like this, big muscles, and then I'll do the bone marrow, break this bone, crack it, and once you crack it all, then you are in big soup. You crack this entire bone, and the patients, you have done this superficial procedure, you are putting too much of pressure in it and damage this entire thing. So this bone marrow process or bone marrow biopsy process is a very, very delicate thing that you have to be careful of. If you are not careful, you can mess this simple procedure and land up in big, big, big trouble. Because if this particular blood vessel breaches, if you breach this particular artery, aorta, and if you have heart pumping out, every cardiac output, we have 500 ml every beat it is coming. So 5 into 500 ml into 60 beats, if it is making 60 into 500 liters, I mean 3 liters blood is getting out like in a minute. So it dies instantaneously, right? So this is what the clinical thing you have to be understand about this bony parts of this. And again, the bone fracture and this particular thing as well can happen, the rib fracture, etc. So that can happen as well. So which is orthopedic complications. Now talking from here, we're going to talk about this particular bony cage, rib cage. This is a thoracic cage. Now this particular thoracic cage has opening. One is opening above this particular superior part, one opening is present in the bottom side. So this particular opening which you're seeing here, which is present, we call them a superior thoracic aperture, right? So this particular superior thoracic aperture which is present over here, marked with the red line, and this one is inferior thoracic aperture, lower one. This is also marked in region. So this is what, there's an entry exit things can happen. Now this lower side, we have this particular partition which is craving over here. We have a lever present in this region, and on top of lever we have a partition made of muscles and the tendons. We call them as diaphragm. We call them as D diaphragm because it's a big one, right? So this particular D diaphragm which is present in here, making a partition between the thoracic cavity above and this abdominal cavity below, right? So this particular lower or inferior thoracic aperture, which is made or covered by muscles, we call them as diaphragm. And above one, we do not have a truly formed diaphragm, but we have some muscles existing in here, making or covering that particular thing as well, but not like the way it is covered in the bottom side. So these two apertures can be called accordingly superior thoracic aperture and inferior thoracic aperture. So front side and back side. They can anatomically, the superior thoracic aperture and inferior thoracic aperture can also be called as thoracic inlet and thoracic outlet. So the superior one, we call them as thoracic inlet, and the other one we call them as thoracic outlet. These two words we have to keep in mind. What do you mean by superior thoracic aperture or thoracic inlet, and the inferior thoracic aperture, also known as thoracic outlet, and their boundaries of it, because they are your exam questions, or sometimes they ask, give a short note about thoracic inlets and thoracic outlets, right? So this particular thoracic inlet, you see that this is more or less oval circular structures which is allowing this blood vessels to get in or come out of this particular thoracic cavity. Bounded above by this particular manubrium, anteriorly, posteriorly we have this vertebra, and on the sides we have the rib number 1, which is covering, which is holding this particular entire space more or less rigid, and top here is reinforced anteriorly or anterolaterally by this particular clavicle. Now what structure coming in or getting out? The structure getting in here is esophagus. That means the pharynx or the food we are taking, mouth cavity, then we have this pharynx, then it is going to be esophagus. The esophagus getting down here. We have this particular windpipe which is going to end up into lungs, gets in here, and as well as we have this heart. From the heart we have the blood vessels coming out and getting in as well, superior vena cava, and as well as arch of aorta and branch of arch of aorta, and the nerves, so number things is passing through. So this is in short about this thoracic inlet. So this much of knowledge, basic knowledge about the boundaries and the contents which is getting in through the opening of this thoracic wall, superior thoracic aperture, also known as thoracic inlet, matters to us. Similar to that, thoracic outlet, which is covered by or patched by diaphragm at the bottom. So it has also have boundaries posteriorly by this particular T12 rib, which is lying on the post side. Anteriorly we have this tiny xiphoid process holding it here. Laterally we have this particular ribs, or we call them as costal cartilage and the ribs, which is making this particular lateral sides, and lower side it is covered by this diaphragm, which is a muscular partition which is covering it. So superior thoracic aperture and inferior thoracic aperture are important, as well as we have to know these words thoracic inlet and thoracic outlet, and the clinical, which I am coming into it. So this is what we have to know about thoracic aperture, superior thoracic aperture, thoracic inlet, thoracic outlet, and the positions of the diaphragm. So diaphragm we have a separate special class. I am just like bringing few points about it, which is a muscular tendinous partition, and this particular structure have holes in it. We call them as openings in the diaphragm, which is structures getting in and coming out, like esophagus, inferior vena cava, descending thoracic aorta. They are getting in and running through these particular holes in the diaphragm. We call them as major openings of the diaphragm. So this particular diaphragm, we have a separate class on it: nerve supply, blood supply, actions, opening, and the closer and this caliber changes of this diaphragm is important to us. We'll learn in a separate class. I'm just like introduce the words. It has two kind of like elevations. We call them as crush of the diaphragm, right? Crush, left crush. And the central portions of this diaphragm, you see that made up with the white shadows. They are made of tendons of it, or musculotendinous structure. We call them central portions of the tendon, where on the top side the heart sits on it. So this is about this diaphragm, and this is about this particular aperture which is related to it. Now coming to this clinical point. Now this particular clinical feature we call them as TOS, which is very common or very popular clinical problem for the medicine on rest of the clinical part is concerned. So we call them as thoracic outlet syndrome. Now before we explained it, what happens out here, this word we call them as thoracic outlet syndrome. In short, we call them as TOS. Now this is a misnomer. Now why we call them as this is a misnomer? Now this particular aperture which you have learned here beforehand, the clinicians call it in a different way like the anatomists call. So we anatomists call this opening as superior thoracic aperture, also known as thoracic inlet. The clinician call it reverse. They call it thoracic outlet. And this one we call them as inferior thoracic aperture. In anatomy we call them as thoracic outlet. The clinician call it the reverse. They call it inlet. So we have a difference of this addressing this opening in the anatomical words and as well as in the clinical words. So for the clinician, this opening is thoracic outlet, and the clinical problem arising out of here, they call it thoracic outlet syndrome, right? So that's why we call them as it's a misnomer, because we have something been established beforehand and we have this particular clinician calling it differently, but still we are keeping this particular entities, both entities separately, but we are addressing this particular clinical problem. So this particular clinical problem, what we are going to address is we have a something happening in this superior thoracic aperture to rule out any confusions. So we have this particular thoracic outlet syndrome where we have a compression or something going wrong at the superior thoracic aperture. Now, if you look closely in this particular region, we have a blood vessels, they are getting in from this thorax side and getting into this particular axilla and eventually to this particular upper arm, which we have already studied. So what we are addressing here, we have this particular brachial plexus trunks which is forming in here in this region. So we have the clavicle, we have this particular ribs over here, and from here we have the heart. From the heart we have a branch of aorta which is shooting a branch, we call them a subclavian artery, which is coming from here. So this subclavian artery eventually crosses over here, reaches to the axilla, we call them as axillary artery. That axillary artery runs to this brachium, we call them as brachial artery. Then we call this as a radial artery and ulnar artery. This is how this particular blood is coming from the heart to our arms. Clear? So this particular artery is crossing this particular superior thoracic aperture. Now this particular vein, we call them as subclavian vein, which is accompanying it, like brachial vein, which is going to be axillary vein, which is going to be subclavian vein, and going to be joining to a vein, we call them as superior vena cava, and eventually going to the chambers of the heart. So whatever the blood is coming through the artery is going back to the heart through the veins. So this artery and the veins having a common course. So this red one and this purple one, if you follow, this brachial artery, axillary artery or the subclavian vein, they are running in this particular course and these actions. Likewise, we have this trunks of the brachial plexus which is coming in here, forming in here and getting into here. You see that? So these particular number of structures are crammed between this superior thoracic aperture, the clavicle, the rib bone and the muscles which is ending over here. We call them as scalene muscles. Now, if you see these particular zoomed out structures over here between the clavicle and rib out, over here we have this rib bone, clavicle above and the rib bone below and the muscle on top, and in between we have the structures coming here is the subclavian artery and the subclavian vein and these trunks of the brachial plexus. Now, if we have something wrong going through this particular narrow region, we have a compression of these structures. Likewise, we talked about the carpal tunnel syndrome. You remember the carpal tunnel syndrome? We talked about there is a tunnel through which this particular median nerve blah 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 goes. If it gets cramped, we have compressions of the median nerve which commonly affects with these functions of this particular thinner muscles and this particular sensory distributions. Remember those things? So similar things happens over here. If you have this particular thing narrowed down, this thoracic outlet or superior thoracic aperture, these blood vessels, if it is cramped and if this nerves which is cramped here, we have likewise syndrome or likewise clinical presentation. So that kind of clinical presentations we call them as thoracic outlet syndrome. In short, we call them as TOS. Clear? Now, let's pause for a moment and think about. Now we have this particular artery which is going in here. What artery? Subclavian artery. What subclavian artery is going to be? Axillary and the brachial artery. Now what happens if you have axillary artery cramped or pinched? So what happens to the artery? So artery টাকে যদি আমরা cramp করে দিই, pinch করে দিই, তাহলে কি হতে পারে? চেপে ধরি যদি, গলা চেপে ধরলাম, কি হলো? Blood যাবে না? Blood যাবে না? So blood won't flowing through this particular artery. So what happens if the blood is not going through the artery? So which part of the body is not receiving the blood then? Arms. So that side affected, right arm or left arm, the side which is affected is not going to receive artery. So what happens to the patient if they are not getting blood? কাজ করতেই পারবে না, রক্ত ছাড়া চলবে না. So we don't have nutrition, we don't have oxygen. So this particular arm will be just like disabled. So কি করে বুঝবো আমরা if we have something cramming there? Clinically কি করে বুঝবে? তোমার কাছে যারা পেশেন্ট এসেছে সে তো এসে বলবে না ডাক্তারবাবু আমার thoracic outlet syndrome হয়েছে দেখে দেন. So they are going to come with some symptoms. So what symptom they will be coming? Some pain or something will be coming on. You will be coming here, and what you will be addressing to identify this particular patient who have or might have some obstructions to the blood flow through these particular arteries which is flowing through. Pulse দেখো, radial artery দেখো, radial artery pulse নাই, তার মানে radial artery দিয়ে blood যাচ্ছে না. ulnar artery দেখার চেষ্টা করব, পারবো না তো ভালো. তারপরে কি করব? brachial artery, brachial artery তে আছে নেই, তার মানে brachial artery থেকে যাচ্ছে না, তার মানে brachial artery উপরে কোনো জায়গা থেকে compression হয়েছে, তার মানে হতে পারে যে brachial artery below above. So lack of pulse will be a feature to the particular patients where we have the cramping of subclavian artery. Clear or not? Same thing if you have this subclavian artery cramped. Likewise, if you have subclavian vein, ওই ভেনটাও cramped হয়ে গেছে, তাহলে কি হবে? যে এসছে সে ফেরত যেতে পারবে না, অভিমন্যু হয়ে যাবে, ঢুকবে কিন্তু বেরোবে না, তা কি হবে তাহলে? So if the blood is not returning back, what is going to happen? Swelling. ফিরতেই পারবে না, খালি এসেই যাবে এসেই যাবে এসেই যাবে, আর ফিরতেই পারছি না তো যাবো কি করে, ফাঁকা হবে না. There will be a traffic jam or it will be huge traffic. So blood is not coming in, bloodless is there, the blood which has reached here is not going back, it will be stagnant here. So it will be as troublesome over here, edema will be there, no pulse will be there. If you have nerve injury there, that means the nerve which is passing through is also cramped. So brachial plexus nerve will begin. What will happen? Lack of sensation. So sensory symptom, motor symptom. So muscle actions will be deficient, sensory symptoms will be there. So this is the way we are going to analyze. the patient will be coming with this kind of problem. So what could have been a possible reason of this particular problem? There will be tons of reasons for this thoracic outlet syndrome. It might have some tumors plugging in, it might have some kind of growth which is happening over here, it might have something like extra ribs or something which is crossing over here. That might be several reasons. We are not going to talk about those reasons, but we are going to talk anatomically how these particular things are happening and how these things are interpreted. Right? So this particular region is very important region over this collarbone or under this collarbone region. We call this particular thoracic outlet region, and there is a chances of cramping of these particular blood vessels which are cutting in or coming out could have a trouble leading to this particular problem. We call them as TOS, which is a compression at superior thoracic aperture, leading to a clinical problem. We may have vascular symptoms, we have neurological symptoms. Clear? So this is how we are addressing this particular problem. Now, going from this particular apertures, we are going to talk about the wall itself. Now, this particular wall we are going to address, and eventually we are going to do dissections in this particular thoracic dissection classes, and many of the cadavers we probably have seen. If not seen already, they have already been done. The thoracic cage is already open and we can see this interior of it. So this is what we call them as intercostal space. Now what do you mean by the intercostal space? Now intercostal space is that particular space which is lying between this particular costae or ribs. So between the ribs, the space that we have, we call them as intercostal space. Right? Now how many ribs do we have? How many? 12 pairs. Now how many intercostal space will be there? 11 pairs, 11 into 2. So right side and left side combining together, we have 22 intercostal spaces. So that particular spaces we are going to talk. So each of this particular intercostal space are housed with some muscles, some nerves, some arteries, some veins, some lymphatics. Now good thing is for us is that whatever the space, whatever the muscles, whatever the content is there, we just address it or put this particular suffix word intercostal, and that covers the name. Intercostal muscle, intercostal nerve, intercostal vein, intercostal artery, and etc. etc. That covers these things. So let's take one at a time to discuss about this particular what we have. Say talk about intercostal muscles. So each of this particular space predominantly have got like 11 intercostal spaces, predominantly have got 3 muscles on them. Now we call them as, all of them we call them as intercostal muscles. Now if you have 3 pairs of intercostal muscles there, we have to address it something with different words whenever you are addressing it to identify individual. Shabbai first year chele, tar moddhe to karu naam ache, sei rokom like something like that you have to address it. So we have 3 pairs of this particular intercostal muscles are there, and we call them as external intercostal, internal intercostal, and innermost intercostal. Now as they are standing, we are calling them anterior, first boy, second boy, third boy, kind of like things. So externally placed intercostal muscle, we call them as external intercostal muscle. Then we call them as internal intercostal muscle, which is lying behind or standing behind this intercostal external one. We call them intercostal muscle, and this most deepest one we call them as innermost intercostal muscle. So 1, 2, 3. This particular nerves which is present in here, we call them as intercostal nerves. So some of the intercostal nerves are typical and some of them are atypical. We are going to talk about. Arteries are there, we call them as anterior intercostal artery, posterior intercostal artery. The veins are there, we call them as anterior intercostal vein, posterior intercostal veins. Lymphatics, we call them as anterior intercostal lymph nodes or lymphatics, posterior intercostal lymphatics likewise. So this particular intercostal space is starting from this anterior side, which is the sternum side, and the rounding about going or reaching to the back side to the vertebral side, which is the posterior side. So this side facing front, we call them as anterior side of the intercostal space, then lateral, and then we go to the back side, we call them as posterior. So entire strip we call them as intercostal space. So from this anterior to posterior, we have this intercostal space. So anterior side we call them as anterior intercostal region, posterior side we call them as posterior intercostal space, right? So we take these particular muscles first. We call them as external intercostal, internal intercostal, innermost intercostal. These 3 of them are there. So The external one is directed downwards and forwards, just like we are putting some hands on our front pocket like this, the fibers are directed like this. If you are putting a hand on the back pocket, that's how this particular internal intercostal is directed backwards and downwards. And this innermost, which is present in here, is basically more or less present in the vertical manner. So this is how this particular external, internal and innermost intercostal muscles are placed. So external intercostal, internal intercostal, innermost intercostal, three sets of muscles are there. Their directions of the fibers is anteriorly, like putting in the front jacket pocket or back side hip pocket. Likewise, the fiber are directed. If you cannot remember, just don't remember. Just remember the name: anterior intercostal, internal intercostal, and innermost intercostals. That's what matters to us. Now, this is how they are placed: anteriorly placed, posteriorly placed, and the third one and last one. Now, this external intercostal reaching to this particular anterior side or close to this particular sternum, the muscle fiber replaced, they become membrane. You call them as external intercostal membrane. Posterior side or innermost intercostal, which is internal intercostal reaching to the back side close to the vertebral side, the muscle fibers are replaced and to form a membrane, we call them as internal intercostal membranes. So they lose the muscle fibers and becomes fleshy, part is gone and becomes membranous. That's why they call them as membranous. You can remember it, don't remember it, don't bother, just remember the names. So this is how they are placed in this particular rib cage. Now, external intercostal, internal intercostal, they are present like this. So whenever you are going to do the dissection, these things will be clear for us to identify. This is how they are placed, like for downwards directed or backwards directed. This is how these particular things should be looking like. But again, don't bother about these particular directions and how these things are there. Now, what do you have to remember? How they are placed, like external, internal, innermost. This is the sequence that you have to remember. Now, these particular muscles are supplied by nerves. We call them as intercostal nerves. Now, this particular intercostal nerve supplies this muscle and helps this particular muscle to perform some actions. Now, what are the functions of these intercostal muscles? They stabilize this particular ribs or intercostal space whenever you are breathing in and breathing out. So, whenever you are breathing in, breathing out, they are stabilizing the chest wall and preventing the bulging out of this particular lung tissues whenever you are breathing in, breathing out. So, they are preventing the popping out of this particular lung tissue whenever you are breathing out. And this particular muscle only helps in forced inspiration and expiration. When do you mean by the forced inspiration and expiration? Now, right now you are sitting and you are breathing quietly. This is known as quiet breathing. Now, your internal intercostal or any of the intercostal muscles are not working. So, when it starts working, it starts really working whenever you are running. So, we are breathing heavily. So, then only it helps to expand this particular chest wall. So, then it works only here. Right now, what they are doing, they are just stabilizing it. They are just stabilizing as you are breathing in quietly and quiet out. This is how these functions are going on. Now, let's talk about the next chapter of it, which we call them as intercostal nerves. Now, to start with this intercostal nerve, we have this particular thing, we call them as dermatome. We call them as dermatome. You see that this is how we split this particular skin part and make this particular kind of like a zigzag spider pattern. But if you look it closely, it has a particular pattern. This is the front side of the body, this is the back side of the body, replicated together, joining here, and this is together. So, our body skin can be divided into segments, like you see that colors are used to divide it into segments. This looks like cubical box, square block or strips of the tissue. Now, each of them have got numbers on them. If you see closely, they are given with these numbers like C, T, like that. So, this stands for the spinal nerves, cervical spinal nerves, thoracic spinal nerve, like that. So, this particular thoracic segment, that's what we are studying here, is denoted by this particular T's. We call them as dermatomes. We call this small strip as, we call them as dermatome. Dermatome. Dermatome means derma by the skin. We call them a skin supply of this particular wall. So, we will coming again. What do you mean by this dermatome? Whenever you are going to study about detail about this spinal nerve. Now, this is about the thoracic spinal nerve, the ideal thoracic spinal nerve, how it should be looking like. We have already studied this in introductory class. It has coming from this part, we call them as, what is this one? Spinal cord. The spinal cord have got central part, we call them as gray matter. The peripheral part, we call them as white matter. Oh, again, I will come again, don't worry about it. So this part we call them as spinal cord, gray matter and white matter. From the gray matter and the white matter, there are two kind of nerve fiber comes over here. We call them as root, anterior root and posterior root. They are colored with two different colors. So anteriorly anterior root, this green one, posteriorly posterior root. We call them as dorsal root and ventral root. So they join together, make a small course, which is the pink one. We call them as common intercostal nerve. After that, it splits again, takes two color shades. These are the brown one, which is moving anteriorly, and this one is moving back side with a picking up purple shade. So this one which is moving purple side and this front side, we call them as rami. So we call them as posterior rami and anterior rami. Now this particular spinal nerve is composed of this purple and the green. This is common spinal nerve, is having a character which is having a sensory character and as well as motor character. That means this kind of nerves are mixed nerves. That means they are capable of functioning sensory things, they are capable of functioning motor things. Clear? Now from there it is getting here. So this rami also is having a two components, motor component and sensory component. That means they are going to supply the skin and they are going to supply the muscles. What muscles they are going to supply? Intercostal muscles. What sensory supply they are going to supply? They are going to supply the skin. Which skin? The chest wall skin. Now this chest wall sensory supply comes here. This is how this particular sensory supply, spinal nerve supplies this part of the chest. Now this how this particular sensory or sensory spinal nerve supplying the chest wall, making a strip like tissues, we call them as dermatome pattern. So they follow a particular rule over here. Now if you follow this particular human body, this particular pattern is identical and universal. That means how this particular nerve is supplying this part of my body is likewise is supplying elsewhere's body. So this is universal dermatome pattern. So why this particular thing matters, we will talk about. Say for example, you see that the umbilicus of this individual. So this umbilicus region, which is abdomen part, this is a landmark part. This is umbilical region over here is supplied by the dermatome T10. This is the nipple region which is supplied by this particular roughly by T4, T5 junctions. This region which T6 which is xiphoid. So we have this particular landmarks. So xiphoid region, that region we have the skin supply is supplied from the spinal nerve T6. The nipple region we have the skin supply coming from T4 spinal nerve. The umbilicus region is supplied by the spinal nerve which is coming from thoracic segment T10 spinal nerve. So this pattern is universal for the human being. So this dermatome pattern, as you are just going to graduate higher classes again and again, will be mattering, will be coming again. We call them as dermatome, dermatome. So this dermatome pattern helps us to identify some diseases or where from this disease is coming. So this gives us a clue. If you remember this particular dermatome pattern of the skin of this nipple region, xiphoid process or umbilical region, you know this nerve supply on that particular pattern or skin nerve supply on that region. And likewise, you can figure out some clinical problem the person is suffering of. Will be coming later on. But let's focus about this particular nerve, a typical thoracic spinal nerve, which is a small question sometimes. So describe and narrate about the typical spinal nerve or typical thoracic spinal nerve. Now, how many intercostal spaces we have? 11 pairs, and we have this in 11. How many spinal nerves we have? Thoracic segment, we have 12 pairs of the spinal nerves. So this particular spinal nerves, the 12 pairs, they are not all of them are restricted to the thorax region. Some of them are restricted to the thorax, some of them are moving elsewhere. Do you follow what I am saying? These spinal nerves, so they are starting from T1 to T12. Now, out of this T1 to T12, not all of them are restricted to the thorax or intercostal spaces. So, those who are restricted to the thorax intercostal space, we call them as typical spinal nerve. And those who are not restricted to this particular thoracic wall or thorax, we call them as atypical. Clear? Now you see that there are some of them are restricted to this particular thoracic wall. Which one? You see this particular chest wall directions over here. See that C3, C4, C5, C6. These fellows are restricted to the thorax wall. Whereas the C7, C8, C9, T1, T7, T8, T9, T10, T12, all of them are going to the abdomen. So how we are going to address it? Typical or atypical? Atypical, because they are not restricted to the thorax. So we call them as atypical thoracic spinal nerves. Likewise, we have this particular T1, T2. They are going to arms. So likewise, they are not restricted completely to these particular thoracic walls. They are going to these arms. So this T1, T2, T3 either is not restricted to the thoracic wall itself. They are moving to the arms. So that's why they also cannot be called as typical thoracic spinal nerve. They can be called as atypical. So if you just like narrow it down, this particular spinal nerves or intercostal nerves, between this T4 to T6, they are known as typical intercostal nerves, and rest of them are atypical. But it doesn't matter, is typical or atypical. This particular course doesn't matter which number is staying and which number is leaving, doesn't matter. Only thing we have to know, there are existence of typical spinal nerves who are restricted to this particular thoracic wall. If you cannot remember this exact number, it's not going to harm anyways, right? Because these numbers are very small things. But what the concept you have to get, that thing is that some of them are present in the thorax. We are going to call them as ideal boys or ideal girls. And those who are not restricted, they are wandering everywhere. They can be called as thoracic spinal nerve, but they are not the ideal examples. Clear? So this number doesn't bother. So know that their typical or atypical existence is there. What matters to us is that how these particular intercostal nerves are branched and what are the functions of it. So this particular intercostal nerves, as we are seeing here, as we have mentioned, this typical intercostal nerves, they have got sensory functions and as well as motor functions. So if you just like see these sensory functions or motor functions of it, this typical spinal nerves are, or this particular spinal nerves are capable of doing sensory action and motor actions. So what sensory action and what motor action they brings, that we have to know. Now talking about the sensory actions, one thing we already know what these spinal nerves are doing. They are picking up the sensations from the skin of the thorax or trunks. We have already learned about the dermatomes. That particular skin part is supplied by spinal nerves. So it is supplying the dermatomes of trunk. That means thorax or abdomen or upper extremity, it depends. So they are taking the sensation from that particular part of the skin. Second part of the sensory action, which is not mentioned here, they supply a membrane. We call them as pleura. Now what is pleura? It is a membranous or living covering surrounding this lungs. So this particular pleura, they have these margins of the pleura, we call them as parietal pleura. So the parietal pleura receives the sensory innervation or touch pain temperature sensation from this particular spinal nerve or typical or atypical thoracic spinal nerves. Clear? So they do sensory functions of the supply to the pleura and supply the skin or dermatomes. Motor part, what do they supply? They supply the muscle. Which muscle? They are present in the intercostal spaces or abdominal spaces. They supply these particular intercostal muscles or abdominal muscles which are present on that particular region. If they are typically present in the thorax region, they are supplying this particular muscle which are present in the intercostal region. If they are moving to the abdomen, they are going to supply the abdominal muscles which are present in the anterior abdominal wall. Now, clear or not? Okay. So, what is intercostal nerves? We are going to address it. Now, we are going to narrow it down, whatever you have learned so far. Once again, this is an exam question that we see. Now, you see that this is again coming back to this particular typical spinal nerve or thoracic nerve, coming with this particular roots, anterior root, posterior root, intercostal nerves, or this particular nerves which is splitting into rami, and this particular anterior rami is bigger and posterior rami is smaller. Clear? Now, out of this, which you are seeing here, it can be called as typical thoracic intercostal nerve or atypical. Which one is typical, which one is atypical, we understand. Some of them are staying in the thorax, we call them as typical. Some of them are not staying in the thorax, we call them as atypical. Now, out of this, which is coming over here, this one is anterior rami and this one is posterior rami, the split. So, this particular anterior rami of this nerve, we call them as, this one only, we call them as intercostal nerves. So, this whole thing we call them as spinal nerve. So, whatever things or whatever the image you are seeing here, we call them as spinal nerve. Spinal nerve got anterior rami, posterior rami. This is coming from the thoracic region, we call them as thoracic spinal nerve. So, thoracic spinal nerve have got anterior rami and posterior rami. And this particular anterior rami and posterior rami, out of these, this anterior rami, we call them as intercostal nerve. Now, this particular intercostal nerve can be divided into two parts. It can be typical or it can be atypical. Atypical means it remains to this thoracic wall, atypical is moving elsewhere, abdomen or upper extremities. So, this particular anterior rami is a mixed version, that means sensory and the motor. That means it supplies the skin, dermatomes, it supplies the pleura if it is supplying that part, and as well as it supplies this particular motor action, it supplies to the muscles which is present in the thorax, we call them as intercostal muscles. So, this particular divisions of the branches of typical intercostal nerves are there. So, it has some branches, we call them as co-lateral branch. So, it splits down from the mid nerve into two branches, we call them as co-lateral branches. Then from these co-lateral branches and as well as this main branch, we have some branches which is going to supply the skin. We call them as lateral cutaneous branch and anterior cutaneous branch. They are going to supply the skin, the dermatomes or the pleura, and the muscular branch. They are going to supply the muscle which our intercostal space have. Anterior intercostal muscle, posterior intercostal muscles and innermost intercostal muscles. So, all these intercostal muscles and this particular part is supplied with this particular region. So, this particular intercostal nerve is an exam short note. So, we have to start it from the thoracic spinal nerve. Thoracic spinal nerve have got two divisions, anterior rami, posterior rami. Only the anterior rami we call them as an intercostal nerve. Intercostal nerve which is present within this intercostal space is called typical, and which is not staying in here we call them as atypical. Out of this particular typical spinal nerve which is present between 4, 5, 6 intercostal space, we call them as typical intercostal space. A typical intercostal nerve have got sensory branches as well as motor branches, and along with that the sensory branches we have a sympathetic branch going on. So, ignore the sympathetic branch right now. So, next Saturday we will talk about the sympathetic division, then we again will be coming back here. Till now this first one or rami communicator, sympathetic one, you ignore it. So, it has got sensory branch and motor branch. Sensory part has got two works to do. It supplies the skin, it supplies the pleura in the chest wall, and the motor one supplies the intercostal muscle. What are the names of the intercostal muscle? Three of them: external intercostal, internal intercostal, innermost intercostal. Clear or not? Good. So, this is about this nerve and intercostal nerve, and this is what we call them a dermatome. So, this dermatome is only for the sensory distribution. That means touch pen temperature. It's nothing to do with muscles. So, it supplies the skin part like this, T4, T6, everywhere over here. So, easy to remember is nipple region is T4, xiphoid process T6, and T10 is the corresponds with the umbilicus. So this is the skin region which is supplying to it. Now, talking about this particular intercostal nerve, how we are going to find this intercostal nerve. So, how these intercostal nerves are placed? You see that this is the back side, this is the vertebral column. Which side? Vertebral column. How we are going to trace this intercostal nerve? Now, this is the back side where you see this particular vertebra, and you are seeing a oblique view. This particular vertebra is placed over here. This particular rib, which is on the back side, the posterior end of the rib present in here. This is this intercostal space. From the back side or posterior part of intercostal space you are seeing. Now, this particular spinal nerve or spinal cord present within this particular vertebral column, and it shoots the branch which is coming here as spinal rami or anterior rami of this particular spinal nerve, also known as intercostal nerve. Now, this intercostal nerve reaches to this particular space on the back side and runs between the muscles. Now, we have three muscles there: anterior intercostal, internal intercostal, innermost intercostal. Now, you see that along with this neurovascular structure, that means nerves are there, we have the veins and the arteries, they run along with that, they have a particular pattern. And this particular pattern, you have to just like remember how this particular intercostal nerves are running between these muscles and how they are going to supply. Now, you see that these intercostal muscles that are present, the anterior rami we have talked about. So, if you just cut this particular space, the intercostal space, so we have this external intercostal muscle, then you have internal intercostal, and then you have the innermost intercostal. Now, this particular neurovascular structure, that means intercostal nerve, intercostal arteries and intercostal veins, the branches of it, they are running in between the muscles, and they are running in between this particular internal intercostal muscle and innermost intercostal muscle. So, within this particular space only, you are going to find this particular neurovascular structures. This is what you have to remember. So, where we are going to find these intercostal vascular structures, in which plane? They are not present at the random sites. So, they are anterior to posterior. If you are addressing the intercostal space from the back side or anterior side, doesn't matter. Between this particular muscle, external intercostal, internal intercostal, innermost intercostal muscles, they are present between the layer 2 and layer 3. Layer 2 is internal intercostal and layer 3 is innermost intercostal. Between the 2 and 3 muscles, we have this particular neurovascular plane where we have this neurovascular structure placed. Now, if you closely look into it, there is a relationship between this particular vascular structure and the nerve. So, most above is the vein, and then we have the artery, and then we have the nerves. So, above down we have a relationship of this neurovascular structure, how they are. So, it's getting complex. So, we have to know this anterior rami or the intercostal nerves, where from they are coming, they are typical or atypical. Now, if they are figuring out to be typical intercostal nerve, where you are going to catch these particular nerves? So, these particular nerves are present between these intercostal spaces in particular layer. In between the muscles, they are hidden. We have to cut through the muscles to reach to them. So, this particular nerve is lying between this particular 3 sets of muscles, and they are lying between the layer 2 muscle and layer 3 muscle, and this is how they are placed. And under the rib tucked in, we have this space, we call them as intercostal groove. If you are just going to study the rib later on in the demonstration class, you are going to see this particular groove, we call them as intercostal groove. This particular groove is visible. So, within here, above downwards, we have these particular structures present: vein, artery and the nerve. So, nerve is lying on uppermost part of the intercostal space. So, if you just like figure it out, this is the bottom side of the intercostal space and this is the above side of the intercostal space, the entire length. So, superior part of the intercostal space, this particular lowermost position, we have this particular vein and nerve is placed, then we have the artery and then we have the nerve. Now, why we have to buy so much of time understand what these nerves is or what these nerves are lying and which plane is there? Because these particular nerves, as you have said, these are the mixed nerves. That means they are capable of taking up sensations, they are capable of performing these particular motor actions. Now, if you are going to do any surgery into this chest wall, we have to just address these particular nerves. So, we have to anesthetize this particular sensory part or these nerves. So, the sensory actions need to be blocked. So, this blocking of sensory actions we call them as anesthesia. So we have put some kind of like drugs to destabilize for a temporarily, so that these nerves cannot feel any touch pain and temperature, and we do the surgery. Now, if you are going to do this surgery in a particular plane, we have to address this particular nerve by giving injections. So how we are going to reach to this particular injections? So this is how we are going to block this particular nerves whenever we are going to do the surgeries, or blocking this particular intercostal nerves. So we call them as intercostal nerve block. So you have to find this particular intercostal space, identifying or counting from this particular ribs, second rib, third rib, fourth rib, and likewise the space. And once you identify this particular region, we have to reach to this particular axillary line. So we remember these axillary lines. So this particular axillary line close to this particular anterior axillary line, or the middle part, middle axillary line, we pierce the skin. Then we have the subcutaneous fascia. Then we have pierced this first muscle, external intercostal. Then we pierce the second intercostal muscle, we call them as internal intercostal muscle. And before piercing the third one, we stop at that particular point. It needs skill, it needs anatomy understanding, it needs your senses to do this procedure. It's a very delicate, very sophisticated skill. It doesn't come by sitting idle or chit chat. You have to just like really knowing it, and then you can only perform, or else you will be messing up, piercing all through and damaging the lung. So everything needs skill, or high skill and high level attentions. So once you find this particular intercostal space, then you have to know this nerve is lying at the lowermost part. So then you have to put this particular thing, we call them as the dropping this particular drug in this particular space, and waiting for some time till this particular nerve catches up the drug and gets disabled for some point of time, and then we can do the surgeries. Second thing is that we have a disease, we call them as herpes zoster. So this particular herpes zoster, which is a viral disease, which you are going to learn in microbiology later on, if you graduate that high. So this particular herpes zoster virus travels along with these nerves. Which nerve? The intercostal nerves. So they travel along the intercostal nerves, and once this particular intercostal nerves they travel, they release a kind of toxins. That particular toxins takes this particular shape of these blisters, and this particular blisters of the herpes zoster is visible following this dermatome. Say for example, you have a herpes zoster nerve, herpes zoster that is running on the nerve which is catching up the spinal nerve, which is T6, thoracic 6. So it will be releasing the toxins based on this particular nerve T6 as it is progressing. So once this particular toxins are following these nerves are coming out, they will be taking up blisters kind of things or burns like this as they encroach to this part of the skin which is supplied by the T6. That means that xiphoid region, there will be showing some blisters. This part of this particular skin will be intact, there will be no harm to it. So we call this as a dermatome pattern of dispersions of toxins of herpes zoster virus infections. So by knowing this, we can trace it like, alright, this is traveling along maybe following the T6 or maybe T6, T5 or T6, T7. So by that you can travel it as this particular nerves are going based on dermatome pattern, you can follow these particular things. Alright. So this is the significance of this particular intercostal nerve, the clinical part, and what do you mean by this particular intercostal nerves, how they are placed in this particular space, and what are the sensory functions, what do you mean by the dermatomes, and the clinical problem based on blocking these particular intercostal nerves that we are going to learn.